we put it up on our
Totally
YouTube
fine.
channel.
Totally fine, by all means.
Cool. All righty. All right. Appreciate that, Angus, for getting that started. All right. So let's go ahead and get started. Welcome, everybody. It's our Tuesday, 3 p.m., no longer 11 a.m. And I think slowly but surely people will kind of get their calendars fixed up and all that type of thing. But we're here. It's 2023, and looking forward to the NAMSP conference. Fire Rescue East is also coming up, so we got a lot of meetings coming up. But excited about today's presenter. So today we have Dr. John Aho, who's a trauma surgeon, formerly with Mayo Clinic, and saw a problem and sought to find an answer and fix it. And oh, Angus, would you want to say something? Okay, never mind.
Nope, sorry.
That's okay. And actually, how we got to today is my fire chief, Julie Downey from Davie Fire Rescue. She emailed me and she's like, "Have you seen this?" And I said, "I have not." And I looked into it, sent out an email to John. He responded right away, and we've asked him for some samples and so forth, and we're going to see if we can evaluate it. But essentially, this is a way to detect whether your chest tube or your needle is in the right place. And John, interestingly, and maybe we'll talk about it afterwards, but one of the abstracts that's going to be presented at the National Association of EMS Physicians in a few weeks from now is about misplaced needles in chests. So I thought you would really like that. So without any further ado, John, thanks for coming. If you want to make any further introductions, please do, and take it away.
Well, thank you for the opportunity. I'm Dr. John Aho. I'll start off with a story about how this whole company and concept and basically how we got to now to today is our second year general surgery residents at Mayo. What we would do is, if you're the first person there before everybody gets there and you think that there's a tension pneumothorax, you and whoever's there do the appropriate thing, consistent with ATLS and while the team's getting rounded up, et cetera. And we had a patient that we had very strong suspicion of tension pneumothorax and isolated one side, young guy, trauma penetrating to the chest, and he was having a very bad time breathing and, didn't have any breath sounds on that side, had dubious tracheal deviation. So we did, what they told us in medical school and when we were interns and everybody tells you to do. We did a needle decompression. And we used, the appropriate at that point in time, 5 centimeter long AngioCath catheter, 16 or an 18, I don't remember. But they tell you in medical school, second intercostal space, mid-clavicular line, and then if you do it correctly, you're going to hear a gush of air. And we put the needle in, expecting to hear a gush of air, and me and my buddy, neither of us heard it. We looked at each other and said, well, shoot, what do we do now? Well, the guidelines would say at that point in time, do another one and then, do a chest tube. So that's what we did. We didn't hear a gush of air on the second time. Eventually, that patient needed an operation on that chest, and we saw needle holes from where our needles went in. And we said, well, why didn't we hear that gush of air? What's the issue there? And that's sort of how we came up with this company and this idea was, why is this not working the way that they told us it was going to work? I don't need to really tell this audience very much about tension pneumothorax, but some basic facts that are really underappreciated. It does have a fatality rate of 100% if it's not treated immediately. And everybody asks me, well, what does immediately really mean? And is it an hour? It maybe takes, depending on the level of trauma that you have, some period of time to build up. But once they have it, you have on the order of minutes, if not seconds, to correct this. And it is responsible, still consistently today, depending on exactly how you look at what data and who you're pulling it from, responsible for 30% of preventable trauma mortalities. The other 2/3 that are preventable typically being bleeding. And the civilian incidence of this condition after trauma is really unclear. You can go back and look at all the papers in the literature and it's estimated about 5%, but when you really dig back to where those citations are coming from, that number is essentially made up. Fortunately, it seems to be made up based on, at least on contemporary data published in September by the group in Pittsburgh, to be about right. So they looked at needles and people that needed subsequent chest tubes who didn't get needles. Their incidence in their population, a large population-based study, was about 0.5%, but they were underutilizing needles by about 9x. So that actually ends up being pretty comparable to what the estimate was. About 1 in 20 trauma patients have the condition. And then the DoD, it's responsible, as of the most recent war, 3 to 4% of all combat mortalities. And so it's not a trivial condition, and it's not a straightforward condition to treat in the field. And the other thing that September study showed was that pre-hospital decompression does reduce mortality by about a quarter. And that's a 24-hour all-cause mortality. They can't attribute it directly to needles, but looking at the 24-hour mortality, those who got needles versus those who did not get needles that needed a chest tube for a chest decompression, had significantly improved mortality rates. And the standard of care, it fails pretty often. And this is actually a picture from a TCCC publication. And you can see a variety of different things that are wrong with this picture, but I'd like to highlight that there's about 6 needles sticking out of this guy's chest. And the issue is, well, when you do the procedure, how do you know it worked correctly? And it's a gush of air is the gold standard that we're still using in 2022. And people attribute other reasons for needle decompression failure rates, but I'd like to really, as my thesis for this talk, really point out that that's a subjective standard, and it's not really appropriate for the location that this is being practiced. Other people have looked at, well, why is this rate so high, including us? Well, it's a needle chest mismatch. The needle's too short for the chest, or the chest is too thick, or too thick for the length of the needle, or other training issues, as highlighted in this picture. There's a couple of them that are put in the wrong spot. But the failure rate, even after addressing all of these issues, going from 5 to 8 centimeters, going up in the girth of the catheter, changing anatomic placement locations, hasn't really moved the needle, pun intended, on that failure rate whatsoever. And this is from our data that we published, looking at clinical effectiveness of 5 centimeters versus 8 centimeter needles. And we measured using CT on patients who underwent subsequent CT evaluation based on their chest wall thickness at their decompression location. And the red ones on the left, this is with 5 centimeter needles on the left, you can see that there's a lot of needles that are quote unquote ineffective, or needles that should reach that using a 5 centimeter needle that are it's completely nonsense to say that it's a needle chest mismatch when you have people reporting effective and ineffective outcomes there. Similarly with an 8 centimeter needle, they had a tension pneumothorax, they got decompressed with an 8 centimeter needle, their chest wall thickness was only 5 centimeters thick. Why didn't that actually work? And sort of going back to, well, it's a placement location problem. There's really not that much difference if you're using a 5 or an 8 centimeter needle between the 4th and 5th anterior axillary, mid-axillary line, or the mid-clavicular line. It's a little bit thinner there for sure, and it's a little bit more standard anatomy that you can teach somebody fairly rapidly for that 4th or 5th anterior axillary line. But if you're using a 5 centimeter needle, you should be reaching almost most of the time, and if you're using an 8 centimeter needle, you should be reaching almost all of the time. And so we did all of this research and all of these studies figuring out, well, what's the problem here? Is it actually a problem with needle chest mismatch or whatever you want to call that? Or is it really an actual issue of we don't have a way to know that the procedure was actually successful in the field? And this happens all across the US when you talk to different emergency medicine physicians, paramedics, firefighters. There's an ambiguity to doing this procedure. There's a fog of war when you're decompressing somebody's chest in the field that leads to an indeterminate outcome. That audible gush of air is very, very short-lived, if it's even audible, in the conditions that you're practicing this procedure. And that was sort of our problem when we did that chest decompression in the trauma bay, was we didn't really know if it worked or not. It ended up that, on operation, that we did reach the chest with that needle. There's a little puncture wound on the inside there, but we had no idea if our needles that we're putting in were failed or successes. So if you don't know if it worked and you think it works about half the time, the tendency is, oh, I'm going to put another needle in. I'm going to put another needle in. I'm going to put another needle in. When in the field, that's really the only tool that you have. And vast majority of paramedic and fire locales that are, or regions, they're not doing chest tubes in the field in the United States. They're not doing finger Thors, and they have needles, and that's what's in the toolbox. So what we need to do is look at what's the actual root cause of these problems. And fundamentally, the pre-hospital environment and the emergency room are loud. They are loud compared to a needle noise that is actually quite quiet. And I'd be very curious at the end of this talk to go around the room and see, in terms of the number of needles that you put in, what percentage of them do you actually, excuse me, do you actually think you heard a gush of air versus were actually successful and it had responses and vital signs? And based on, I don't want to taint the data here on my informal survey at the end, but it's not very many people hear this when they're doing the procedure. So the fundamental problem isn't actually whether the needles are reaching or not. It's we don't know at the time of procedure if they've reached the chest or not into the pleural space, because the outcome of the procedure is based on a gush of air. So what if we can interrupt this pre-hospital hamster wheel that people have a tendency to get on when they're doing needle decompression, and instead could replace it with an objective metric that's a non-auditory based metric? And we had kicked the can around on this, and it wasn't a flash of insight. It was refined iterations and trying to discover what the root causes of this problem were. And keep in mind that when you have a tension pneumothorax, that air actually leaked from the lung. It's like air you breathe out. And that's why it's building up. It's building up there over time. It's leaking from the lung and it's filling that space, and eventually it's under pressure. We already have a tool for that. That's colorimetric capnography, colorimetric indicator paper, colorimetric pH paper, the same stuff you use for endotracheal tubes. And that basically detects CO2 in the relevant range that's in the pneumothorax. We said, okay, well, does this really fit? Is this something we can engineer a device around? Is this appropriate for the field? It ends up that, yeah, it's lightweight, it's portable, it's small, it's inexpensive. It's already familiar to practitioners in the pre-hospital and early hospital space, that color change. Urine, as in it's the color of urine, you're good, right? So there's not much additional education here that has to happen for the pre-hospital providers. So this is the cheapest paper probably ever published in chest. So basically what we did was we took novice and expert operators, those who had done needle decompression, those who were familiar with the procedure, and those who had been trained on basically the basics, like a mannequin, but had never actually done the procedure in the real world. And we asked them, do the procedure on a pneumothorax that we generate. So we took, we injured the pig's lungs, didn't insufflate CO2, didn't artificially gas this in any way, and let the pig develop tension pneumothorax by vital signs, and then asked the provider practitioner to do a chest decompression using a needle, using the standard of care gush of air, and then using our color-based CO2 sensor. And I'll just play this video here real quick. Pay attention to this upper right-hand corner here. It's purple right now. Operator pulls the plunger out. Thing turns yellow. And so the interesting thing here that happens too is the decompression of the gas along this needle, this device here, that actually reverses, that color change occurs before vital sign changes occur too. That vital signs change over the course of a minute or so. This changes on the order of about 3 to 5 seconds. And then so we did a receiver operating curve analysis. The other thing I didn't mention before is we knew whether or not they got the needle into the correct location in the chest or not. We had a thoracoscope in there looking up at the chest wall where they were doing this. So we knew what ground truth was, whether that or not they got the needle into the location. And interestingly, the standard of care, whether you were an expert or a novice, you were basically doing a little bit better than guessing when you put the needle in. And this isn't a semi-quiet animal research lab operating room. And keep in mind, the needle girths, the gauges have gone up over time. And if you think about that for a second, if you have a very, very big straw and you have a stream of air going through it, it's going to get quieter as the needle gauge goes up. And so over time, I think what has happened is as we've increased these needle gauges, we've actually quieted that signal down. We've made it so that it's harder to detect if you're actually successful with the procedure or not. And so this device, this technology basically removes that ambiguity, and it makes it so that, at least in the animals, it seems to work better than the standard of care, and arguably perfectly. So it really does provide that binary yes or no, removing that operator subjectivity. It's durable. It persists for a period of time on the order of a minute. If you were to clog off the needle, that color change persists for about a minute. However, if the needle gets clogged up, it does shift color back the other way and let you know that that needle is no longer patent, it's no longer decompressing. Designed by myself and several colleagues at Mayo, and basically we did that compelling animal data that I just showed you, but I'm also going to show you a little bit of our human data too. We have cornfield trauma, we have tractor trauma at Mayo in Rochester, so almost all of these patients were blunt trauma patients. And a lot of them were in the situation of agonal blunt arrests. So in our facility at that point in time, they all got bilateral needles just as rule outs during transport, which is an important negative control. And then the patients that had autopsies, we did look at to see whether or not they had evidence of that needle reaching or not. So in patients who had tension pneumothorax, it turned color the way it did in the animals. And in patients with blunt agonal, which is basically the negative control, they did not have any color change. And then so that's all well and good. That's all in a research lab, internal at the world famous Mayo Clinic. How do we get this out to the rest of the community so that we can actually have a device that's usable by clinicians? That's basically what I've spent the past year doing. Fundraising around this device. We have enough money to get this to FDA clearance. We submitted our FDA paperwork back in December. So right now we're just waiting on FDA clearance for this. We've had prior discussions with the FDA around what they'd want to see for that documentation. And we took care of it and have it all together, and it's planned to be commercialized here probably in the next several months. I'd say probably you're looking at April for an FDA clearance, but we're looking for feedback. We're looking for comments. Is this something you'd use? Is there something you'd change about it? What do you all think? But first, I'd just like to have tell me some war stories about, have you had a time where you got the needle in, but you weren't sure you got it in? Tell me about that. Like, what's that practice like in your communities?
See, Dr. Pepper, you want to jump in? I know you have to hop off in a few minutes. You want to make some comments?
Yeah, the first thing is it's really great that you brought this up, because everything they teach you that you're supposed to see, like tracheal shift, I probably have seen hundreds of tension pneumothoraces over my career. I've unfortunately been practicing for about 45 years, but I never really saw a tracheal shift that I can even think of, and so I didn't even bother looking for it. Let alone the air pop up. Now, the issue is that I agree with you, is that once you keep poking holes in there, you got even more risk for hitting something else that could be a big thing to hit. And so I think this is a thought, and it's been good. I've always used long needles, gone very slowly, but yeah, you don't get the gush. That's good for TV. I thought we could use it for that. So, but very rarely you get that. Sometimes if I'm chest tube in, you will get that sometimes, but not what you do with the needle, right? So
yeah, that's a great comment, Paul, and I think many of us have experienced the same thing, which is, and I think John, you mentioned it very well, that it's kind of very dubious and it's unclear oftentimes. We had someone on our webinar a few months ago who developed a device to help people get the right spot. But what you're saying is that even if you have the right spot, you may not even be in to begin with, which is another big issue.
Yeah, the SAM thoracyte would be the one that's typically used for that. So it's a three-dimensional problem, and as your colleague mentioned earlier, you can get the two-dimensional problem pretty good. That's something you can train based on surface anatomy. That's just a question of explaining how long the clavicle is and going lateral to the nipple and finding the sternal angle of Louis, or going wherever you're putting it. That's a two-dimensional problem. When you're talking about depth, now you're talking about a three-dimensional problem. And with the 8 centimeter long recommended catheters that are typically recommended now for ATLS and some of these other guidelines, that is a long, there's a reason they call it a spear. It's huge and not appropriate for every patient. You have a small, skinny person, 5 centimeter will do just fine. But it's a question of getting it to the correct depth so that it functions, so that you can temporize it and move on to other therapy. The issue what's going on right now is, in that picture with the gentleman that had 6 needles coming out, half of those needles were about halfway out. And they probably weren't deep enough. Some of them were too medial. You do more pokes, you're going to hit something you don't want. You have wasted time on your trauma resuscitation, wasted time during transport, wasted ambiguity, questionable legal issues of not getting the device in the correct location. Whereas with something like this, you could do it once and get it done correctly, move on to your next thing in your ATLS algorithm, and remove that ambiguity. Because even the most experienced people that I've talked to in this space, they say it's a coin flip every time they're doing it. And this gush of air that they teach in medical school, with a 10 gauge catheter, fat chance, pun also intended on that one.
Yeah.
Peter, we're just talking about trauma cases here. There are other medical cases which we have to come across. That complicates it even further, particularly if it's a pink puffer or whatever. But also, I think it brings up what you both brought up as a great point, is that everybody thinks of the air rising and it's up there at the top, or you're squeezing it. These things, the pockets can show up in weird places, especially if there's blood in there as well at the same time. So, so I think there's a combination of things that we need to be looking at here. But I think it's great discussion, because we just brought this up last week about how to manage people with post-traumatic circulatory arrest, as I call it, because they're not quite yet in cardiac arrest, but they're getting there. And so I think this is timely, and it just really, I like it. I'm very intrigued. So it sounds really good, John. Thank you.
Yeah, you're welcome.
I love the tractor people, because not enough people know about that. That's difficult situations that you have. Yeah.
I have a quick logistical question, John, which is, does this device, it kind of hangs off the side, if you will? Is that the mechanism?
So it uses a standard lure lock fitting. So that, and we did that purposefully. We could have bundled it with a certain manufacturer or another manufacturer. We said that's not the right way to go for this, from a business case, for a variety of reasons. It's going to limit the rate of adoption. So we put a standard lure lock fitting on there. If one wanted to put it on a pigtail catheter, they could. If one wanted to adapt it for a chest tube, they could. If one wanted to use it on an ARS, a spear, an H&H, a pneumo dart, doesn't matter. They can connect it in whatever scenario they want for whatever chest decompression that they're doing is clinically appropriate.
Sorry.
Who is that about about how can we get samples to check it? Who's AK? See who that was.
Yeah, no. So we have Dr. Nir Huss, who's a good friend of mine. He's a trauma surgeon at Delray and St. Mary's, and he's super excited about this. I'm not sure. I think, John, you sent some his way, right?
Yeah, I did. I sent some over to him. If you have some interest in looking at them, partnering in some way, potentially doing a study, like that's part of what we're trying to do right now. Now is outreach time, where we basically are trying to figure out, because changing clinical practice on a procedure that's 50 years old is difficult. So talking to people who understand this problem, because I can talk to the paramedics, they get it right away. I show it to them, I stick it in a balloon. They say, oh, that's just like the endotracheal tube type stuff that we already use. Yeah, it's the exact same thing. Same color change, and very minimal additional education is required. in a lot of EMS locations, they don't even need to change protocol, right? Because it doesn't alter that gush of air. It's an adjunct. So they can use it in that way in the pre-hospital space. But we're looking for partners, and that doesn't just mean financial partners. We're looking for people to how do we change practice here? I've been able to adjust that practice with some of our data for going from a 5 to an 8 centimeter. That's mostly my fault and our group's fault. The alternative anatomic location, that's also partially our group's fault. But we really want to deal with this issue because it's 1/3 of preventable deaths. It's so stupid. And all you have to do is get a medical grade straw into the right spot, and you've at least temporized that. And yeah.
Just only because we only have 3 minutes left, what I would propose is that, we have large systems here. You have a lot of people on the phone here who are medical directors, EMS leaders, state people from all over the country. And we would be happy to kind of roll this into what we do. Obviously, it would take a little bit of time to gather the right numbers, but I think putting the protocol together, Dr. Pepe is the research guru. Go ahead, Paul. Yeah.
Yeah. So just want to know the AK was Abdel Curry. So he's over in France. So we can send it over.
Yeah.
Okay. And then
Awesome.
John, well, I'll try to get the information for Peter, but we ought to present this with Maine Eagles next week. Hey, how are you? We ought to bring it over, have him come on. It's too late today. I got too many things going on today, but have him come on next week because that's really a good follow-up to last week's discussion, right?
Okay. Perfect.
Hey, great. In France, I assume, right? In the dispatch center? He popped up there for a second. Yeah. Oh, you can't talk to the dispatch center. That's why. Okay. So anyways, just want to let you know, we'll get you plugged in with him as well because he's a big leader in the European medicine committee, having been the president of one of their key organizations. So that'll be a good night.
Awesome.
Nice
Awesome. Well, listen. Yeah. Go ahead, Paul.
601, and I'm switching over to Eagles. Okay. See you later.
We'll see you over in a minute.
Thank you.
Well, first of all, I wanted to thank Chief Downey for bringing this to my attention and to our attention. When I first saw this, I'm like, this is brilliant. We should be having it. Just real quick, because I know a lot of people on the call are probably wondering, what do you expect the cost to be, John, when it comes out to market per device?
That's an excellent question. So the MSRP, that is the suggested retail price, is on a $25 unit basis. So, and then people are like, oh, that's too much, that's too little. It's actually right in the middle based on what we looked at. So the average number of chest decompressions that patients across the US are getting is somewhere around 4. So each of these needles, the Spear is a great example. Spear costs $40 per unit. The TyTech or the H&H or the Pneumodart are around $20, $25 a unit. And then if you go simpler than that, you're looking at $9 per unit, MSRP. Now that's whatever your facility contracts is fine. But on the average, if we save 1 needle per patient out of that 4, we broke even on economic costs for the value assessment committee type stuff. So not only are we doing the right thing for patients, you have confidence in the people that are in the field that are doing it, and they call back and they say, yeah, it turned yellow. And then you can say, there's no arguing with it turning yellow. Same thing for the endotracheal tube, shift over to that practice for the field intubation stuff too, right? So it's $25 per unit. They're probably going to be bulk order discounts through distributors and things like that. But it's about the cost of a needle, and it definitely saves additional needles. And more importantly, it saves trauma time and screwing around in the ambulance, which, trying to figure out if a needle's functional or not and troubleshoot that in an ambulance, that's not a situation you want to be in.
Awesome. Fair. Very fair. Thank you so much. All right. Well, listen, thank you so much. We've recorded it. I'm sure this will get a lot of views. Dr. Pepe's invited you to next week, where he'll ask you to do like a 3-minute to 5-minute version of this presentation.
Yeah, sure.
To another audience. You're welcome to stick around if you want. I see you put your information in the chat. Thanks for doing that. And again, thanks, Chief Downey. So, all right, everyone, stick around. We appreciate you, John, and I'll be in touch with you on email. And I'll also
for the opportunity and happy to try to make it better.
Awesome. All right, guys. Thank you so much. All right, everyone. Stick around if you want to stick around.